Dr. Wendy has given me the green light to begin. I'm going to start one place, since I'm not a host of this, but I am going to ask everyone at this point, as more people are trickling in, please mute your microphones so we don't catch any background noise. I've noticed most people are, but I just want to remind everyone as a courtesy to please do that for us. And we're past 12 o'clock, so I'm going to get started. I just have a brief introduction for Dr. Davis, who we're going to be listening to today. I really don't think I can adequately describe, nor do I think any of you want to hear my thoughts about how excellent Dr. Davis is as a division director. He's highly respected in the United States as a forensic pathologist amongst his peers. He's a former president of the National Association of Medical Examiners. He's a recipient of the Milton Halpern Award from the American Academy of Forensic Sciences, one of the highest honors that they can bestow upon a member. To those of us that are lucky enough to work in his division, he's an incredible mentor and a friend. I'd really like to tell you all how Dr. Davis is an accomplished baker, runner. He speaks Russian. He has a greater appreciation, love, and knowledge of music than anyone else I know. But we don't have time for that today. And what we're going to do, though, we're going to spend our time talking about what our office and what our world in Jefferson County has been dealing with for several years. Dr. Davis took over the Jefferson County Coroner Medical Examiner Office as chief in 2013. Since then, we've been dealing with opiate-related deaths at a rate that hasn't slowed down, and that's what we're going to be talking about today. The work we do in the forensic division is difficult at times. At times, it's very, very sad. However, we continue to do good work in this office because of Dr. Davis's leadership, his support, his enthusiasm, his bread, and his music. So without any further, I'm going to turn it over to Dr. Davis, and he's going to share his screen and go through his talk with us today.
Thank you very much, Dan. Of all the things that you said, what I most cherish in my colleagues is their friendship. That is very important. There we go. So the first thing I want to say is a word of advice to, well, thank you for inviting me to speak. I'm honored to be asked to speak. And now I have a word of advice to anyone. If Adam Wendy ever approaches you and says he is interested in having you speak for the for grand rounds, if the question, you just politely ask the question, do you have anything in particular you want me to discuss? And you expect that his reply will be, oh, whatever would suit you, that's easy and no problem. That's not the answer you can expect. You can expect that he'll say, I want to hear about this. And what he wanted to hear about was COVID and the opioid epidemic. And I'm glad that he pushed me to present this because it's a timely topic and one that we need to hear about. So of course, COVID is a pandemic. So we've got a pandemic and an epidemic happening concurrently. And we're going to see at the end how that's playing out here in Jefferson County and I think in the United States. So this is a map of the world that shows COVID. I actually got this, as you see, a month ago as I was starting to put this talk together. This morning, I checked in the New York Times, and the United States wasn't quite as dark today as it was a month ago, but still we're about as dark as you can get in the world. We're among the world leaders in COVID cases. And then here's the map that shows death rate from opioids, and you'll see that we're leading the world there too. In fact, there are only 2 countries that are leading the world in both COVID and opioid deaths. One is the United Arab Emirates, I really don't know much about circumstances there and have no experience that I can share with you, but I do know some about things in the United States. So we're going to talk about the experience here in the United States. But we're going to start with a little bit of history. When I was an undergraduate student, I took a course in archaeology from Dr. Ned Neighbors. And he talked about this, he talked about that. But the most important thing I learned from that course was when Dr. Neighbors told us, never make the mistake of thinking that people that lived in the past are not as intelligent as you are. He said they're every bit as much as intelligent as you. They just didn't have the advantage of years of innovation that you are able to enjoy. Believe me, he said, if they could have had flush toilets, they would have had them. And that really stuck in my head. And so I always like to look and see, well, what has happened before? There's really not much that happens that hasn't happened before on this earth. Of course, as a physician and a scientist, I really don't get a lot of ancient accounts by physicians or scientists because there weren't so very many of them, and those that there were weren't writing particularly. But there were people that were observant in their own way. And I'm particularly thinking of historians and poets. So if you want to know about things like infections and intoxication in the past, you need to look to historians and to poets. So let's start with infectious pandemics. There are many. These are just four that would fit comfortably on one slide that I could show, and they seemed particularly pertinent to our time and to our talk today. The bubonic plague, there have been several iterations of it, but the specific one that I'm thinking of, the Black Death, swept through Europe in 1346 to 1353. It had involved Asia too. It's estimated that 140 million people died, a third of the population of the earth at that time. It was a devastating pandemic that completely upended the social order, as we shall see. The Spanish flu, we actually hear quite a bit about these days because it was also a respiratory viral infection in the same way that COVID is a respiratory viral infection. And it caused many deaths in 1918 to 1920. About 3% of the people died at that time, but they were particularly vulnerable to death were young, otherwise healthy people. And that was very distressing. Death is distressing, period. But when someone who's older and lived their life to its full dies, it doesn't have the same poignancy for us that the death of someone young who still had, you would have thought, life to live. So the Spanish flu got great attention at that time, but then it passed. More recently, in 1981, began the HIV/AIDS era. And since 1981, in the last 40 years, 36 million people have died, a smaller fraction of the world's population, but a devastating number nonetheless, and still an ongoing pandemic. But now, beginning in late 2019, we have COVID, which is in fact new. Pandemics are not new, but COVID is new. It's the novel coronavirus, after all. And we've already, in a little under 2 years, had 5 million deaths from COVID. Now, there are more people now than there were 100 years ago. And that represents 0.06% of the world's population. There have been many other epidemics that we know some of, and some that we don't. Cholera epidemic, smallpox, malaria is endemic. I was delighted when I looked at the newspaper this morning to see that a vaccine against malaria for the first time has been approved by the World Health Organization. So perhaps there'll be some relief from the 500 million or so deaths per year caused by malaria. But there are other pandemics and epidemics that we know nothing about, particularly the supposition of the diseases that were brought by European explorers to the Americas and decimated native populations. Those sorts of things have not been memorialized in literature, but some things have. Thucydides wrote about the Peloponnesian War, and as a part of that, he recorded the plague of Athens. Later, we have Boccaccio's account of the bubonic plague or Black Death as it passed through his hometown of Florence. Still more recent works, Edgar Allan Poe wrote The Masque of the Red Death, which is generally thought to have been inspired by a cholera epidemic in Europe. And another story that you may know from movies, but Francis Hodgson Burnett's story, The Secret Garden, not in the movies, but in the book, the very first chapter explains how the female protagonist becomes an orphan because her parents and all of her household die in a cholera epidemic. And talks, particularly Poe and Burnett both talk about the suddenness of death. It just, you go from being sick to dead in hours or a day. And of course, that was true for the bubonic plague as well. Well, it would be better for this slide if I were Dr. Maggie Galusi and I could perhaps relay some of this to you in the original language, but I am not and I cannot. But I particularly want to focus on Giovanni Boccaccio and his work, The Decameron. It's in a collection of 100 short stories that Boccaccio wrote through a framing device where 10 young people, well-to-do young people, retire to the villa that one of them owns outside Florence so they can escape the plague. But the plague went through Florence in 1348. As these young people are there, they tell each other stories, and that becomes the framing device for this collection of 100 short stories. But the first 10 or 20 pages of the book concern Boccaccio's experience with the bubonic plague. And I want to read you some of what he wrote, because I want you to consider as you hear it, how similar that may be to experiences we have here. Boccaccio said, all sick persons were forbidden entry to the city, and numerous instructions were issued for safeguarding the people's health, but all to no avail. Of course, 14th century Italians did not understand the germ theory and certainly didn't know anything about Yersinia infection, but that didn't mean that they were trying to get better or keep from getting sick in the first place. So what happened there? Well, Boccaccio tells us. He said that all the advice of physicians and all the power of medicine were profitless and unavailing. And why was that? He goes on, perhaps the nature of the illness was such that it allowed no remedy. But, he said, perhaps those people who were treating the illness, whose numbers had increased enormously because the ranks of the qualified were invaded by people, both men and women, who had never received any training in medicine. And all of these people claiming to be able to provide medical care were ignorant of the disease's causes and were not prescribing the appropriate cure. So there was no social media or internet available in Boccaccio's time, but that didn't mean that people with no particular training were offering their recommendations on how best to treat the illness. Boccaccio said that the disease spread so rapidly from person to person and led to death in hours. Had he not seen it with his own eyes, he would have not believed that it was true, but he assures us that it was true. And pertinent to the point of this lecture, Boccaccio talks about how different people responded to the plague to try to save themselves. Well, they responded in different ways. Boccaccio says that some people chose to withdraw from society and live a sober and abstemious life. Of course, there were other people who chose to go another way, and they took the opposite view, maintaining that an infallible way of warding off the appalling evil was to drink heavily, enjoy life to the full, go around singing and merrymaking, gratify all one's cravings whenever the opportunity offered, and shrug the whole thing off as one enormous joke. So how did these various approaches work? Well, Boccaccio answers that question too. He says, of all the people who held these various opinions, not all of them died, nor, however, did they all survive. I think that's fascinating because as I reread that at the beginning of the pandemic and being confined to my home, I found that everything that was happening to me, he had already described years and years before, 750 years ago. Let's talk a little bit about intoxication. Humans have a long history of using intoxicating substances. At the head of the list is alcohol. That is no accident. But tobacco and betel nuts both contain nicotine compounds. Khat and coca leaves contain stimulants. Mushrooms and other substances, for that matter, provide psychedelic experiences. But alcohol is king, in part because alcohol is readily available. Wherever you would have some sort of substance that contains carbohydrates, then bacteria and yeast can act on those carbohydrates to cause fermentation. And so basically that means wherever you have grapes to crush or grain to form mash, you can have alcohol. So alcohol is well described in world literature. And I particularly like that the Bible describes two aspects of alcohol. It's enjoyable. In Psalm 104, the writer says wine is available to gladden the heart of men. But it can go beyond enjoyable and become destructive. In Proverbs 21 says, wine is a mocker and strong drink a brawler. So literary accounts of intoxication typically focus on comedy or tragedy that comes from being drunk. But here, the question that confronts anyone who chooses to use alcohol is really set in the stark ends of the spectrum. And that is, if you're going to alter your mood or sensorium, where do you draw the line between what's enjoyable and what's destructive? I certainly hope that everyone's familiar with the Odyssey and how Odysseus saved his men from the Cyclops Polyphemus. You may recall this is the giant one-eyed creature who had imprisoned Odysseus and some of his men in his cave, and he would eat 2 men for breakfast and another 2 men for dinner every night, and then put a rock over the cave so that they couldn't move it. They too big, they couldn't move it, they couldn't escape. But Odysseus was clever, and he has a trick. He offers Polyphemus a flask of particularly potent wine. Polyphemus is unfamiliar with wine, and so he starts to drink it, and he likes it. He enjoys it so much that he tells Odysseus he's going to make him a special present. He'll eat Odysseus last because he appreciates this wine so much. But Polyphemus continues to drink the wine and gets drunk and begins to vomit after he passes out. And this stupor allows Odysseus and his men to take a stake and blind Polyphemus by poking out his one eye. This account of how a person can go from merry to drunk and then unconscious and vomiting is pertinent to the practice of forensic pathology. We hear and see such accounts regularly in our practice. So let's move a little bit forward into medieval times and talk about Geoffrey Chaucer. Chaucer's family had been in the wine business for at least 2 generations. So when he speaks of drunkenness, he doesn't only speak of it as a human who might have experienced it or seen it, but as someone who's really sort of in the business. There are 2 particular places that Chaucer mentions extreme drunkenness in the Canterbury Tales. One is the drunken miller in the Reeve's Tale, and one is the drunken cook in the prologue to the Mansiple's Tale. In both of these places, Chaucer describes the men as being pale and breathing heavily, snuffling or wheezing as though they had asthma or were snorting like a horse. This is a description of the increasingly infrequent respirations that occur in a state of deep intoxication, where a person goes overlong without breathing until sufficient carbon dioxide accumulates in their system to finally trigger a breath. Every forensic pathologist practicing in America has heard the statement that someone passed out and then it's invariably they were, quote, snoring loudly, end quote. And then later they weren't breathing at all. and we invariably find that they have some sort of opioid in their system. You can reach that point of being so comatose that you're in danger of stopping to breathe because of alcohol. Alcohol is a central nervous system depressant, but you have to drink something on the order of 20 glasses of wine or take 20 shots to get there. These days, people are able to reach that profound level of coma much more quickly using opioid drugs. And that's where we see this sort of change most often. This particular graph has got a lot of information in it. It was created and published by the National Institute on Drug Abuse, part of the NIH, using data made available by the CDC and particularly from the National Center for Health Statistics, where my colleague, Margie Warner, she was able to join the talk today, and I'm glad to have her, but you heard her speak to us at this Grand Rounds back in March of this year. And Margie and Holly Heidegard have gathered data throughout their career, and we're seeing some of that here. So what we're seeing is a graph, of course, from the turn of the century on to 2019, and it's showing the rate the number of deaths from various substances. This orange line is synthetic opioids other than methadone, primarily fentanyl. The light blue line is psychostimulants with abuse potential, primarily methamphetamine. For all subsequent versions of this slide, because we're going to spend some time on this, I'm going to change all these to shorter descriptions so it'll be easier to read. And I'm going to tell you what was happening at the time that these events we see portrayed on the graph took place. We're actually going to go back and start in 1995, because that's how we got to where we are today. In 1995, the American Pain Society began a campaign for treating pain. And as part of this campaign, a pretty aggressive campaign, they trademarked the phrase, "pain is the fifth vital sign." And they got other agencies to join their call for increased treatment of pain. Now, I'm going to speak for myself here. I think that good medical care requires that you keep both eyes firmly fixed on the patient and the good of the patient. And I'm going to say that if you've got one eye fixed on trademarking your phrase that you came up with, I fear that you might have one eye focused on financial income more than on the good of your patient. But this isn't a time of the evidence-based medicine. So we can't just do these things willy-nilly. There would have to be some sort of evidence that would indicate that we could treat pain freely with opioid medications. So where was that evidence? Well, I'm going to show it to you. It's here. This is a letter to the editor that was written to the New England Journal of Medicine and published in 1980. And I'm going to read it to you. It says, "To the editor, recently we examined our current files to determine the incidence of narcotic addiction in nearly 40,000 hospitalized medical patients who were monitored consecutively. Although there were nearly 12,000 patients who received at least one narcotic preparation, there were only 4 cases of reasonably well-documented addiction in patients who had no history of addiction. The addiction was considered major in only one instance. The drugs implicated were meperidine in 2, Percodan in 1, hydromorphone in 1. We conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction." That is the entirety of the article, this letter to the editor. And that was the foundation for claiming, it was cited many times, claiming that opioids could be used to treat pain and there was no risk of addiction. There's a lot of information that could have been reported that was not reported in this, like how many people got one narcotic preparation, how many got 2. Were the ones who developed addiction treated longer than the others who didn't? None of any of that's present here. The only thing that's present here is something that people used as justification for using opioids freely and assuring people that they could not cause addiction. Let's move up to the year 2000. By this time, the American Pain Society had gotten several important actors to join their campaign to end pain. The Veterans Administration, the Joint Commission, the American Medical Association, the American Academy of Family Physicians, and various patient advocacy groups. There was attention brought to Congress. Congress was requested to declare 2000 to be the start of a decade of pain control. And Congress did that. So 2000 to 2010, the decade of pain control. And so from 2000 to 2010, prescription opioids led the cause of death from overdose really on into the mid 2010s. By 2003, it was already apparent that the number of overdoses from prescription opioids had doubled since the decade of pain control began. And in fact, the Substance Abuse and Mental Health Services Administration, SAMHSA, called a special workshop for various individuals who used methadone or worked with methadone as part of their daily practice. As it happened, I had written one article, that had the word methadone in the title. And the people organizing this meeting found that article and asked if I would attend as an expert on methadone as a forensic pathologist. And I agreed, and so I was at the meeting. There were also physicians there who represented pain management clinics. There were physicians who represented drug addiction treatment clinics. There were individuals who were part of hospice care. And then there was Randy Hanslick, who is the chief medical examiner for Fulton County over in Atlanta, Georgia, and a prolific author of research for forensic pathology. So all of us were there. And I have to tell you something that happened while we were there. Various ones went around the room and said, everything's going great. Everything's going great. It got to Aunt Randy and me, and we said, well, we say things aren't going so great. People are dying from this stuff, and you've got to take it into consideration. They are, in fact, addictive drugs. I'll never forget, after some tense exchanges and some heated words, one of the pain medicine physicians said, the only problem we have is that you, and he pointed at Randy and me, that you people keep saying that people die from this stuff. If you'll stop making that statement, then there will be no problem and we can all continue doing this. And Randy and I said, well, we'll stop doing it when it ceases to be true, but because it's true, we'll continue to do it. And so all of this data you see here come from death certificates that forensic pathologists were completing and where they were indicating whatever the cause of death was, be it prescription opioids or methamphetamine or what have you. So I'm proud of us for that. In 2011, the decade of pain control had ended, and we now had quadrupled the number of deaths from overdose from medical opioids than we had at the beginning of the decade. By this time, the American Medical Association and the American Academy of Family Physicians had both rescinded their endorsement of the American Pain Society's campaign. In 2012, opioid prescribing peaked. Now, remember, this is showing number of deaths from overdoses, not prescribing. But physicians wrote their peak prescriptions for opioids in 2012, and then the numbers of prescriptions began to fall, so that by today, or by 2019, the last time we have data, the number of medication-grade opioids prescribed by physicians was nearly half what it had been at the peak. Physicians were moving away from this devastating idea that pain had to be treated with something that would alleviate the pain. But here I must mention that I've talked about ancient writings, but we had our own writings, or at least entertainment, that could have helped us avoid all of this situation. In the year 1987, the movie The Princess Bride was released. And in the movie, the princess, who's named Buttercup, is kidnapped, and then she's kidnapped or rescued a second time, it's not entirely clear to her, by a man wearing a mask. unbeknownst to her, that man wearing the mask is her long lost love. And when she speaks of how he won't let her die, or because she can't ever find her long lost love, of course he knows he is that love. He upbraids her for that, that she would give up hope, and she replies, "You mock my pain." And he, Wesley, replies, "Life is pain, Highness. Anyone who says differently is selling something." For some reason, that line always stuck in my head. And if we could have remembered that in 95 and 2000, we would be in a better position now than we are as a nation. But we did begin cutting back on prescriptions in 2013. So by 2015, prescription opioids were not as available as they had been. And so people who are now physically addicted to opioids had to find opioids somewhere else. And the only place left to go was the street. So you see that beginning in 2010, heroin starts to increase in causing deaths. Fentanyl is already starting to increase too. And the combination of fentanyl and heroin is now exceeded medical opioids for causing deaths. By 2016, fentanyl has now sped ahead and surpassed any other opioid for causing deaths from overdose in the United States. So how did fentanyl displace heroin? Well, that has to do with some economics of business. Heroin is a well-established drug, and the drug cartels knew how to get it, they knew how to make it, they knew how to distribute it when the opportunity arose in 2010. Heroin is made by methylating morphine, and morphine comes from opium poppies. Opium poppies grow in a dry, warm climate, particularly in a mountainous region that extends across Asia from Turkey to Pakistan to Burma. But you have to get that morphine or convert it to heroin and then ship it across the Pacific Ocean somehow if you're going to get it to America. And that costs money to ship. There's the possibility that it'll be seized by agents, drug agents. And so it's really expensive. The cartels in the Western Hemisphere began growing opium poppies in areas that were suitable for growing such plants, but they also explored the possibility of substituting fentanyl for heroin. Fentanyl is a much simpler molecule. Heroin has to be derived from morphine. That's the easiest way to make heroin, and morphine comes from the poppies. But fentanyl can be made from simple compounds in a laboratory. The cost of making fentanyl is about 1/10 the cost of making a similar mass of morphine. And fentanyl is more potent than heroin. And so you can cut it even more and make further profit for that reason. So the cartels in the Western Hemisphere have transferred much of their business from heroin to fentanyl. It's just a business decision for them. It has an additional benefit for them besides. Once people are addicted, they want to get something powerful so they can have a higher high than they had the last time, or try to achieve the same sort of high they got the first time before they started developing tolerance. In Chicago, back in the mid 2010s, they didn't know it at the time, but fentanyl had come in. All that the medical examiner's office in Cook County knew was that people were dying many more people than they were accustomed to from drugs that were bought in this one area. So they talked with the health department and they put out a public service announcement. Please, please be careful. Do not go to this area and buy drugs because they are causing people to die. Well, by the next day, they had twice as many deaths because what they unwittingly had done was to advertise where to go and get this more powerful opioid, which turned out to be fentanyl. There's one part of the country where fentanyl has not been particularly damaging, not the way it has been elsewhere, and that's in the Pacific Northwest. Why is that? Well, it's because the Pacific Northwest uses a different sort of heroin than most of the rest of the country. Most of the country has heroin that looks like this. Fentanyl looks just the same as this. So you can substitute fentanyl for heroin and no one's going to know the difference. But the Pacific Northwest has long used a kind of heroin that's called black tar. Sometimes it's chunks like this, other times it's more liquid and looks like creosote. But the people that use this draw it up, cook it, draw it up, inject it. They get horrific abscesses, but they do not mistake this fentanyl for black tar heroin. So the Pacific Northwest has been fairly spared from fentanyl deaths, though they have plenty of drug deaths, to be sure. Now let's go back to this graph. I want you to see that in addition to the rise of fentanyl and the displacement of heroin and medical opioids, cocaine and methamphetamine are also on the rise. So economists have taken an interest in this. From 1975 to 2000, they studied drug and the economy, and we're trying to figure out the relationship between the strength of the economy and health. And during this 25 years, what they found was that as the economy got better, people's health actually got worse. As the economy got worse, people grew healthier. They offered various explanations. Perhaps when the economy is worse, fewer people can drive, so they walk more, they can't afford to buy cigarettes or something like that. And so their health gets better. If their health gets better, then dying would decrease. If their health gets worse, then of course there's more deaths. But that ended in 2000. Since 2000, studies have shown little or no relationship between the strength of the economy and various causes of death. But this particular report from 2017 made two important points. One was that young white males with low educational attainment are at an increased risk for death from drug overdose. That didn't really pertain to the economy, but they couldn't help but notice that this was true. But because they're economists, they're arguing for ways to try to treat the economy. So they said strongly that treatment for substance use disorders yields good return for expense, they're economists, during times of economic downturn. I think that's important. They're encouraging us to continue to provide drug treatment programs even when times get tight financially. The other concept that came into economics around this time was the concept of depths of despair, that people, because they are hopeless, they have no hope of a job, they've lost money, or so they either commit suicide or they just give up and start using drugs. But Boccaccio told us some of this already, right? That when the plague came, that some people just gave up and said, let's have a good time and maybe we'll be dead tomorrow, but at least we'll have fun now. So here then is a graph showing the economy. That's the dark blue line at the bottom. This is showing the unemployment rate. That's a proxy for the economy. If unemployment is up, then things are worse. When it falls, things are better. These middle two lines come from data from the National Center for Health Statistics. You've got overdose deaths in the United States, the overdose death rate here, not the absolute number. And then the green line is overdose death rate in Alabama per 100,000. And you can see that unlike maybe from 75 to 2000, here, it doesn't really matter what the economy's doing. The line keeps trending upward. So what about this purple line at the top? Well, that's where I've taken data from our office and calculated the overdose death rate for Jefferson County based on our findings. And you can't help but notice that it's considerably higher than the death rate for the rest of the nation. Why is that? Well, the reason is because our office follows the recommendations by the National Association of Medical Examiners for the investigation of potential overdose deaths. Not every office is able to do this or does do this. It costs money to perform toxicology analysis, and some offices don't have a lot of money. Happily, our office receives the financial support that it needs. We investigate all deaths to see whether there's the possibility of overdose. And so I submit to you that if we had full information for the rest of the nation, the curve for the rest of the nation would be more a flattening out of this purple line. Well, you'll notice that all these national data end in 2019, just when COVID starts. So that's what we really want to know, right? What's happened since COVID? Well, I do know, and I can show you for Jefferson County. And here it is. Since 2019, overdose have exploded in Jefferson County. We had a 30% increase in overdose deaths in Jefferson County from 2019 to 2020. And we're not quite through with 2021 yet, but we're a long way into it. And we're 30% ahead of last year. So the COVID era has caused overdose deaths to skyrocket. I've read in the paper that there are preliminary data that show the same sort of 30% increase around the nation. So you can expect to see a similar sort of slope for the nation too. Let's go back to this statement about young white males with low educational attainment being at risk for increased death from drug overdose. An article from this year in the Annual Review of Public Health reports manual laborers, such as those working in construction, are at particularly high risk of dying from an opioid overdose. They're also more likely to report medication opioid abuse than are other workers. This is partly associated in their analysis with precarious employment conditions and with missing days of work due to illness or injury, or perhaps simply not showing up, I'm adding. There are other occupations that are also at risk for overdose mortality, and they include healthcare support, that's ominous, and food preparation. Well, I'm going to ask the question whether manual labor and food preparation and other industries, if you have a drug habit, and only about 1% to 2% of the inhabitants of the country have a regular illicit drug habit. If you do have a habit though, if you need a job, you're only going to get employed by a place that isn't performing drug screening. And so that selects certain types of jobs. I mean, we often get individuals who have overdosed in our office and they have paint smears on their blue jeans because they're in construction and painting and that sort of thing. These sectors are the sectors where testing for drugs is unlikely. And so I propose that those job sectors are attracting people who, among others, but they're attracting individuals who use illicit drugs regularly. Now let's go back to our graph of what happened in Jefferson County in the since COVID. I can get unemployment data for the nation since COVID, and here it is. We had a huge bump in unemployment in 2020, but that didn't mean that people didn't have money. They got their stimulus checks as part of the COVID program. Again, only a small fraction of individuals regularly abuse drugs, but for the ones who do, who are unemployed with money coming to them for stimulus, now there's nothing necessarily to keep them from indulging in their habit. Boccaccio again told us to expect this. This is just the eat, drink, and be merry sort of approach. Some people behave better in times of stress. Some people behave worse. But when you behave worse with fentanyl, which is highly lethal, then death is a likely outcome. So this is the sort of thing that we're seeing in Jefferson County. I think we're going to see it in the nation. I'm not saying that the stimulus program was a bad idea, but this is a consequence of the stimulus program. Now, I've got one more graph to show you, and I'm going to talk a little bit. In the next graph, we're going to remove the economic data and replace it with the death rate from COVID. And here it is. As striking as our increase in overdose deaths were in Jefferson County, the deaths from COVID dwarfed the overdose deaths. So what can we do? How can we recover from all this? And I'm going to stop sharing and go back to just presenting as me. Let's talk about the things in turn. COVID is an infectious disease. We actually have a way to treat COVID or make it so that anyone who's infected with COVID is much less likely to have an adverse outcome, specifically death, from COVID. That's easy, it turns out. The hard part is getting people to actually get immunized. But whether we get people immunized or not, I want to give you this word of encouragement. Every pandemic that's ever been, even the bubonic plague, ended at some point. This is going to end at some point. It's hard to live through, but it's going to end. Now let's talk about drugs. As difficult as it is to get people immunized, I'm telling you that's easier than getting people to stop using drugs. Once you become addicted to drugs, it's very hard to stop. Some do, but they often relapse. Public health initiatives to try to treat addiction focus on things that are at really the macro sort of scale. Risk factors for deaths from illicit drug use, or just for illicit drug use, period, are stressful life events, areas of poverty, if you live in an area of poverty, and lack of opportunity. In a word, being in a hopeless, that's the word, a hopeless situation. On the scale of public health, governments can work to try to create opportunities or opportunity structures to redress imbalances that exist in current opportunities. And I applaud that. But there's really not much that I can do about that as an individual. So let's talk about the individual level. Disability and chronic pain are associated with isolation and depression. There's been plenty of isolation, plenty of depression, plenty of opportunity to sit around and do nothing but think about what you could do to try to avoid this difficult time in which we live. And for some, it becomes a feedback loop that spiral into despair and then suicide or drug use, which can end in an overdose. So how can we overcome hopelessness? It turns out that we can do something, but it demands much of us. The economists are correct. We need to invest, but it isn't just money that we need to invest. We have to invest ourselves. So I'm going to finish by telling you about Dr. Oakley Ray. Dr. Oakley Ray taught psychology at Vanderbilt. That's where I went to undergraduate school. As it happens, that's where I also went to medical school. Dr. Ray had a popular course in psychology, freshman intro course. It filled every year, 120 students would take it every year. I was not one of the students that took the course. But happily, I got to go to Vanderbilt to medical school, and Dr. Ray came and spoke to us there once. And I vividly remember what he told us. Every year on the first day of his class for these freshmen, he gives them a 2-question quiz. It's really a survey. The first question on his quiz is, have you ever used illicit drugs? Yes or no? Now, the second question depends on your answer to the first question. If you said no, that you've never used illicit drugs, you're 18 years old, you've never used illicit drugs, the second question said, well, it's not for lack of opportunity. You could have gotten them if you wanted. So why did you not use illicit drugs? The second question was, if you've used illicit drugs, what could someone have told you to stop you when you were getting ready to do it? And Dr. Ray said that he invariably got the same sorts of answers to each question, the second question. The people who said no, they had never used illicit drugs, always cited a relationship as the reason they did not start using drugs. Now, they might say a different sort of relationship or different words, something like, I wouldn't want to disappoint my parents. God wouldn't want me to do this. I wouldn't want to hurt my family. Something like that would always be the reason they didn't use drugs. There was a relationship that was more important to the individual than any promise of whatever ecstasy some drug could offer for a moment. For the individuals who said, I did use drugs, their response to the question, what could someone have told you that would have stopped you? They invariably said, nothing. By the time I decided to use drugs, there was nothing that anyone could say to me that would have kept me from using drugs. So I say this is good news because it means take heart, keep after it. Don't ever stop devoting yourself as a caring person to your family and to your friends. It really matters. It doesn't matter if your children, when they're teenagers, are insolent now and then. I mean, it matters in a way, but it doesn't mean they're not watching you. It doesn't mean they're not listening to you. It may actually mean they're testing you to see, do you really care? Will you come try to save me if I'm a smartass? If you care, they know you care, and it really can make a difference. So I want to offer that word of hope. If we will just care and conduct ourselves, extend the care that we feel as physicians to our lives as human beings, we can save people. It's easier to save them from ever starting than it is to save them after they've begun. But we can even save the ones after they've begun, because the people who do stop stay stopped again because of a relationship. There's something more important to them than whatever they were getting from drugs. Drugs don't fill the hole in your life. They just end up making it wider and deeper. But we can work to fill the holes in each other's life, and that'll make for a better world, really. And that's all of my talk. Thank you for your attention.
Thank you, my friend. I appreciate that. We have a few moments for questions, and we'll try and take those. I want to give enough time to Dr. Sanderson, because Dr. Sanderson wishes to speak at the end as well. So if people are willing to put questions in the chat, we'll go that way. Or if someone has a question, please unmute yourself and fire away.
Well, I'll start. I've got a question here in the chat. Dr. Lutovsky asked, who sent that letter to the editor? Well, there are actually names on the letter. I decided not to show them in my talk. I thought that would distract from the letter itself, but you can easily look it up and see who wrote the letter. I can't tell you that I knew who the people were, but there were names on the letter. Any other questions?
Great talk, Greg. Wanted to ask you, for people that die from homicide, suicide, accidents, do we have statistics that show that also drug use is even higher than it was before 1995, like suggesting that people that die from homicide, suicide are more likely to be in the effect that they were historically?
So the drugs are involved in these other deaths
In some way, a crime or whatever.
So that's an excellent question, but it's got a kind of a complicated answer. So on one hand, it's very difficult to get that information. At the national level, that information tends to come from death certificates, and often the sort of information that you're describing is not put on the death certificate. Now let me answer it though from our perspective, because we know our cases. The answer is yes. Often there's a history of drug use in individuals as suicide, homicides. They actually may not use, but yesterday I had 4 autopsies. Okay, 3 of them were overdoses. 1 of them was somebody selling drugs that was shot and killed. If you got rid of all drugs, I've told people this for you. If you got rid of all drugs, including alcohol, 90% of our work would be gone. There would be nothing. If you got rid of that, that's one. If you got rid of the second thing, if you got rid of infidelity, 90% of what was left would be gone. People ask me sometimes, what can we do to stop this? And I tell them those 2 things, and then they always say, there'd be nothing for me to do. There'd be like 3 cases a year. And when I tell people those are the 2 things, they say, well, we can't change that. And I'll say, yeah, I think you're right. but you can help mold people and help them see that there are other ways. Oh, I'm sorry. One other aspect of your question, Silvio, if no one else has a question at the moment, is the National Center for Health Statistics, where Dr. Warner works, is the place that gathers all these death certificates eventually from the various state health departments. And they realize that there's a lot of information available in the files of coroner medical examiners, much more information that's on than is on a piece of paper, even electronic, essentially sheet of paper. So they're actually working with offices, ours is one, to try to figure out ways that we can start sharing information that's in our database with these public health departments so that they can start to get at the sorts of questions that you answer at the national level. Do you have any other questions?
I think since there's no other questions, Dr. Sanderson, we're going to hand off to you. Oh, here we go.
Yeah, thanks. Just want to say a quick word. Next Thursday is our annual Listinsky Lecture in Glycobiology. We have a very, very distinguished international leader in the field of glycobiology, Ajit Varki from UCSD, very accomplished man, member of the National Academy of Medicine. And he's going to speak on the topic here you see on the flyer is glycans, the dark matter of the biological universe. And if you'll look down a little further on the flyer, you see the objectives of this talk. So I want you just to know that this is going to be a broad-based talk. It's not focused on one or two particular carbohydrates or particular aspect of glycobiology. It's really more broad-based, and I think it's going to be very interesting to everyone that tunes in. He's going to, if you look at the objectives, he's going to talk about appreciating glycosylation as universal to all living things, and understand why evolution has never generated a cell devoid of glycosylation. And lastly, realize that glycosylation is as essential to life as the genetic code. So very broad, and I think will be very entertaining and interesting, and I encourage you all to tune into that. Thanks.
Before we go, Dr. Davis, I did have an observation. I did look up the gentleman who was the chief author of that 1980 paper. Apparently, he has made a particular point of stating that his was a closely monitored inpatient population, and that he never said anything about outpatients, which I don't think completely explains things, but it is an object lesson in not going beyond the evidence when trying to do evidence-based medicine.
I thank you. I think he provided some key that some people wish to use to force a lock. Well, it's
Excellent
2 minutes
lecture.
to the hour. Thank you all for having me speak. I really appreciate it.
Thank you, Greg. Excellent lecture. And I want to welcome Professor Han-Fei Deng. He's on the Zoom to our group. And all the others that I saw some new names here.
Thank you.
Mhm.